and we will go to our last talk of the day. Andeas Bartsch will be back with us to talk about cerebrovascular reactivity mapping, promises, and pitfalls. And then we'll have a little bit of time at the end to answer some additional questions that are not directly related to one talk, but could be general. Okay, I won't unlock. You've only unlocked it one at a time, though, right? Because okay, good.
And now to something completely different. So we will start with a little quiz, and then I will talk about what CVRM promises, how to perform it, and if there are alternatives, how to analyze it, and what are the pitfalls, and what to conclude from it and what not. And then we will do re-quizzing. So, what is CVRM? Is it mapping the cerebrovascular response to exogenous vasodilatory IV contrast agents such as carbogen? Is it mapping perilesional bold responsiveness to breath-hold maneuvers? Or is it mapping bold and/or CBF responses to reversible vasodilatory challenges such as carbon dioxide? Give your votes, please. Okay. So you're doing pretty good. Would anybody say none of the answers is correct? Then we will come back to this. I would favor answer 3, but you could argue about the challenge. Because you could argue if a challenge means something that we expose. So the natural fluctuations are excluded, right? So, but answer 3 would be my favorite answer. Then, second voting. Signal changes in CVRM are approximately 0.1 to 1% bold, lower than in dynamic susceptibility contrast perfusion, but normally higher than neurogenic bold, or blood carbonation level dependent, BCLD, as opposed to bold. Your votes, please. No votes yet. Okay. I love that some people are picking the BCLD because I made that up. So, yeah, actually, the majority was wrong. It's lower than in DSC perfusion, but normally higher than neurogenic bold. Now you can argue, what does normally mean? We can discuss that. Okay. And finally, what's the clinical relevance of it all? Does an attenuated or abolished cerebrovascular reactivity, is that thought to indicate a need for revascularization, intraoperative electrical stimulation mapping, or both? Your votes. Okay. So the majority, 25%, 30% go for ESM, and 70% for both. Okay, we will do a re-vote at the end of the talk. The promise of cerebrovascular reactivity mapping is to detect neurovascular uncoupling, which is a diminished or absent functional hyperemia in response to some neural activation. And the hyperemia manifests itself as an increase of CBF, CBV, blood oxygenation, such as bold, detected by fMRI. So that's the promise. What are potential causes for NVU? This potential causes for NVU are an exhausted cerebrovascular reserve due to an increased vasodilatation at baseline of the microvascular bed in one or all microvascular arterial territories, such as in severe stenosis of arteries supplying the brain. Or, that's another thing, another story, a reduced or lack of or paradoxically reversed hemodynamic response due to pathological vessels around brain lesions or in brain lesions, due to local vasodilatation or vascular steal, for example. So now, in steno-occlusive arteriopathies, the idea is, in fact, that NVUs or a reduced cerebrovascular reserve capacity indicates the need for revascularization. This is a Moya-Moya case with hypoperfusion in the right territory, in the territory of the right middle cerebral and anterior cerebral artery, and it was an direct STA to, as a superficial temporal artery to middle cerebral artery bypass was placed here, but it failed. So this is very complicated surgery, and only few neurosurgeons can do that. And that's a Moya-Moya case, classical Moya-Moya case. And that was the pre-surgical cerebrovascular reactivity mapping, and the post-surgical showed the failure. So you don't want to submit anyone to such surgery who does not need that. And the other clinical relevance is that if we have no cerebrovascular reactivity in or around a brain lesion, then the idea is that any fMRI, like task-based fMRI or resting state fMRI, will not give us any useful information because we can't measure any response. So these people should go, well, some people could argue if you nevertheless tried fMRI, conventional fMRI, but these people should undergo ESM. And that's why some people have argued that this is an evolving standard or even an established standard for clinical functional imaging. To understand a bit about cerebrovascular responses, the first thing you need to know is and you probably all of you know, that there's autoregulation of the CBF. CBF stays constant for an arterial blood pressure between around 60 to 160 millimeter Hg. And if you exceed an arterial blood pressure, what happens then? You get a breakthrough of the autoregulation. But normally, we're never in that state. However, if we have microvascular hyperemia or vasodilatation due to increased carbon dioxide concentration in the blood, due to stenosis, due to lactate in a tumor, this requires some upstream arterial vasodilatation to avoid any drop of downstream pressure, okay? That's a very basic concept, and we need to know about it. We don't actually know for sure how this upstream vasodilatation happens, if this is a conducted mechanism, a myogenic mechanism, or flow-related, but it does happen. And the response of the brain vessels to hypercapnia is vasodilatation and an increased CBF, okay? And this is probably mainly due to the increase in extracellular protons, okay? And this is a profound increase. If you inhale 5 or 7% carbon dioxide, your CBF increases by 75%. That's a lot. So in bold CVRM, we are not measuring such high signature changes. So how to perform it? Essentially, there are two ways. You can run a bold sequence or an ASL sequence, or you can run a sequence that is able to give you both. I would recommend to run it at 2 or 3 millimeter isotropic, matched to your task or resting state fMRI acquisition. You normally, like if you repeat hypercapnic challenges, you normally need 5 to 10. So you need 5 to 10 minutes acquisition time. For ASL, you probably need less because there you're measuring the flow increase. You're measuring the 75% something. So you don't need so many repetitions, or you can't even do any repetitions. If for a challenge you, for example, inject acetylazolamide, which you can do, but then due to the long half-life of the drug of 2 to 6 hours, you only have a single exposure, okay? But you have lots of signal. But this is not what people normally do. What people normally do is they do breath hold maneuvers. You can do it end expiratory or inspiratory, or they have people inhale carbogen, which is 5% carbon dioxide. And you do this for 10 to 20 seconds and alternate with a rest, about 40 seconds. You keep your rest periods a little longer because this breathing thing can be quite stressful for the people. You do the physiological patient monitoring with a respiration belt and logging. If you have access to it, you also measure end tidal or arterial partial pressure of carbon dioxide. And then you run a couple of supplemental sequences, such as field mapping, such as a normal anatomical scan, such as DSC perfusion, and probably an angiography sequence. First case. Anybody knows what this is? I have no chocolate anymore, but I just delivered one. So any idea what this patient has? So what's not normal here? On the T2, well, look at the eye first. Patient comes first. This is not normal. These are melanocytic hamartomas of the iris called Lisch nodules. Lisch nodules. And here you have no flow void on the left. This is the right internal carotid. And you have no flow void on the left. And you have like a net of vessels here. By just these two images, you can make a diagnosis. It's a neurofibromatosis type 1. Typical Lisch nodule and intimal hyperplasia. So the intima of the arterial vessels gets hyperplastic. Only in 10 to 15% of the cases, so that doesn't happen with all of the patients with neurofibromatosis, but this constellation of Lisch nodules with this missing flow void is quite typical. And you see, again, you see the missing flow void and the missing contrast in the terminal carotid in the time of flight angiography here. That's not okay here. You also see that the patient has, what Natalie mentioned, a fetal variant of the posterior cerebral artery here. So we don't expect any, and that's not included in the stenosis. We don't expect any perfusion abnormality in the territory of the posterior cerebral artery. You also see that the post-communicating anterior cerebral artery on the left gets the blood mainly from the right side. So we probably don't expect a lot of perfusion abnormality on the left, in the territory of the left anterior cerebral artery. But we do expect perfusion abnormality in the left middle cerebral artery territory. And the question is should this patient get an extra to intracranial bypass or not, okay? And that's what you have to figure out. nothing works. No. This is the perfusion, what we do first, perfusion time series. And you see a signal change of almost 100%. This gives you lots of signal. We don't get close to it with Bolt, okay? And you can analyze this by the same methods you have for Bolt imaging. You can analyze that model-driven or data-driven. And that's a model-driven analysis. It's the time-to-peak map based on an arterial input function, which is normally our hemodynamic response function, now is our arterial input function. And we can look how much is the time-to-peak delayed. And if you now look to the right side, the scaling of the color bar indicates a delay of about 11 seconds. The map is okay-ish. It's not great. If we now run independent component analysis, we find one component with an early, what we saw time to peak should be called time to dip because we are lowering the signal. But because it all comes from CT perfusion, it's called time to peak, okay? So the dip of the signal is around here, and that looks like all the other territories that are not effective, like the right brain and the posterior cerebral artery anterior. And the left middle cerebral artery territory is apparently delayed. The dip comes later, right? And this is, again, about 11 seconds. So this is done before performing any CVRM mapping. We are now doing the CVRM. The first thing to do is monitor the respiration. So you ask the patient not to breathe, and you check, did that work? So in blue, you see the recordings from the respiration belt. And you can see it worked. So the patient was following the commands. Then how do we model now what we expect if we do a model-driven analysis? And you can convolve your recordings from the respiration with a respiratory response function. A respiratory response function has been established by Rasmus Bern with a very comprehensive and nice work, and it shows two things. The RRF is slower than the HRF, for one, and it's more variable. It can be shifted by 20 seconds across individuals. So if you tell people, hold your breath, and you compare the delay of the response, then this can be shifted. Even though the people did comply with the breath hold perfectly, it varies by about 20 seconds, which is a lot. Now, what do we get? And this is crucial. If we just model our Bolt CVRM breath hold time series thing with a single EV convolved by this respiratory response function. So the breath holds command are here in black. The first EV, the breath hold commands convolved by the respiratory response function, is the one in the dotted line in red. And if you just do this, and this is what most people would do, then what you see is a lack of activation, a lack of cerebrovascular response in the left medial territory. So you would say this person is lacking, there's a reduced cerebrovascular response. Pooh. Patient should undergo surgery. But now, if you include the knowledge that the perfusion in the left medial territory is delayed by 11 seconds and add another explanatory variable, delayed exactly by these 11 seconds, then you see, no, well, it's delayed, but the amplitude and the temporal, like it's temporally delayed, but it's present all over the medial territory, and the amplitude is okay. So there's no reduced cerebral vascular response. There's no NVU, no neurovascular uncoupling. And you can get the same by ICA. And now, and this I find kind of cool. If you look at the components you get from the ICA, and this is, you don't put anything into the ICA about your known perfusion delay. You have these components, and if you measure the peak, the distance between the peaks, this is just 9 volumes in 1.1 seconds. It's exactly these 11 seconds that you have from the perfusion. So 2 different modalities, one with contrast agent and the other under breath hold, show exactly the same thing, that you have a delay in the perfusion in the left hemisphere. And the conclusion was no surgery. Okay, this is a very similar case, and I just walk you through it. That's a patient with a Moyamoya disease, a 50-year-old female with a left M1 stenosis. It's kind of untypical because Moyamoya usually involves the terminal ICA, the internal carotid. And in her case, it was not involved. So it's a bit untypical, but it can happen. And the only thing to know is that you can have stenosis from other reasons, like arteriosclerosis or other reasons, other vasculitides and things again. And what you see here is she has a bit of T2 hyperintensity in the junctional hemodynamic border zone. So you're wondering, is this patient safe, or should she undergo surgery, bypass surgery? Not working. Can you? Oh. So time to peak delay, in her case, not as much delayed, about 7 seconds. Same thing with ICA, like with the other patient. So normal perfusion and the delay is 7 seconds. And then same story as before. Single EV, you get a false negative result on the left hemisphere. This is not to say model-driven analysis is good as long as you have your model right. But if you don't know if and for a function like the respiratory response function, where we know that there's such a huge variability, you may be better off with ICA. And with ICA, you say the same thing. DSC perfusion drop, the delay, absolutely matches the delay of between the 2 components in the cerebral vascular reactivity mapping. So no surgery for this patient either. So are there alternatives? So now we are doing very laborious stuff. Like we spend hours on analyzing the data and thinking about it and blah, blah, blah. And is there an easier way to do it? Yes, there is. And this is transcranial duplex sonography. What you do there is you have people inhaling carbogen, and normally what then happens is you have a vasodilatation and you can measure a increase in the flow. And it's quite easy. So normally a normal vasomotor reserve, that's how the sonography people call it, is around 33%. And 30 to 60%. And this patient had 33. So we are saying the same thing. And this is a different case with a right terminal carotid stenosis, where to show you that TCD can, in fact, pick up a reduced vasomotor reserve. In this case, it was only 7%. So this patient was a good candidate for the surgery. So what are the lessons? The lessons are, 1, perfusion delays propagate directly into the delayed cerebrovascular responses. And you should only consider cerebrovascular responses or the cerebrovascular response capacity abnormal if it's reduced or delayed beyond this. And perfusion abnormalities may mimic neurovascular uncoupling in CVRM. And using a single regressor is probably not a good idea. And you have a very cheap and effective alternative in terms of transcranial Doppler. So now to the brain lesions, if I can go. Evidence for neurovascular uncoupling in and around intraaxial brain lesions. So again, we ask this question, why is it so important to know about the intra or extraaxial location of a brain lesion? Well, if you cut a lesion out and it's intraaxial, then you have to go through the brain parenchyma. If it's extraaxial, you may have to go through the brain parenchyma, but normally you don't. Like if it's easily to reach, like a convexity meningioma, you can cut out without traversing the brain parenchyma. So there are two lines of evidence trying to, or making a case for NVU in or around intraaxial brain lesions, such as gliomas or metastasis or whatever. One is a reduced or lack of cerebral vascular reactivity in and around the brain lesion, and the other has nothing to do with cerebral vascular reactivity mapping per se, but it's just measuring asymmetric or decreased Bolt signal fluctuations, like in this patient. This patient has a right hemispheric tumor. You can see it here, and you can see that the response adjacent to the tumor, resting state or task or whatever you use, is reduced. And then people claim this is neurovascular uncoupling, okay? Especially if you see that despite preserved function. Because if function is reduced, you don't know, right? Because the function would not have probed vascular response. Nothing, okay. But is this really true? First, neurogenic Bolt could, at least in theory, be preserved despite an attenuated or even abolished cerebrovascular response, because we are having a different stimulus. And altered perfusion in the pathological vessels in and or around the brain lesion could cause false negative of your cerebrovascular response mapping. And then, as to the second point, mass effect, infiltrated tumor, perifocal edema, etc., all this may lead to effectively less neuronal tissue within a given volume, which may reduce the Bolt response, while the neurovascular coupling is actually preserved, right? So I don't think that these previous two lines of evidence are good ways to establish neurovascular uncoupling. However, this is the same case as before, where I said radiology is chronology. If that's a whole take-home message for today, I'm happy. And here, in this lady, you see the time to peak map was pretty even. So there was no perfusion delay in the tumor. Right? I put the perfusion without the overlay here. So you see the left supramarginal tumor here, and you see the perfusion is the same like in the res parenchyma. There's no difference. And this is a case where you can have a hard time with ICA, and you need to think how to do a good ICA on it. But I found some ways, and even with ICA, I didn't see any evidence that the perfusion is abnormal in the tumor. And that's the cerebrovascular reactivity map. Let's start with the bottom. In red now you see the breath hold commands, and in blue the locked respiration. And you can again see that the patient complied. And now for Mark Jenkinson, you see head motion stops when you hold your breath, which is what you would expect when you stop your breath motion. And the head motion parameters I estimated by Flirt reflect that. So you have less head motion during the breath hold, which of course, when you do motion correction or you include motion parameters as a confound, now then you have a very strong correlation with the paradigm, but whatever, okay. And the maps actually show that the cerebrovascular response to breath hold maneuvers in the tumor is reduced, okay? So no perfusion abnormality, but reduced. And then some people would say, oh, is mapping really helpful? Well, it was, because we found, aside from the arcuate fasciculus and the typical Wernicke activations, we found a little activation spot in the anterior supramarginal, so supra-Sylvian fissure gyrus. Okay, the supramarginal gyrus is the gyrus bending around the Sylvian fissure. And it has a lower portion and the anterior upper portion, right? And right there was a bold activation to a phonological fMRI, active fMRI task. And this actually, when you look at this, you can see right this spot over there. So in this case, there was a good correspondence between the CVRM and the mapping. I don't have a good lesion case for you to show where CVRM was abolished and all in the lesion and bold reactivity from like resting state or task-based fMRI was as well. I'm on my finishing line here, but could you give me the next slide? Okay. Go one back. Could you go one back? Back. Yeah. Okay. 4. Go forward. Next slide. Okay. Okay. What to conclude from it and what not. Generally, we perform cerebrovascular reactivity mapping to demonstrate a lack of territorial or intra or perilesional activation. That is a failure to reject the null hypothesis. And it's always difficult to statistically ascertain a failure to reject the null hypothesis. While cerebrovascular reactivity mapping may indicate a reduced bold reactivity or neurovascular uncoupling, it is itself based on uncoupling the flow, cerebrovascular, the CBF, from the oxygen metabolic rate, right? Because when you're breathing carbogen, the metabolic rate of your brain does not change, at least not a lot. And it's susceptible to false negative detections. So CVRM, in my view, is not yet ready to be declared a standard of clinical care and should not preclude patients from language or memory fMRI, okay? I think the first line is probably a little, like I saw Mark making his thought about the failure to reject the HNO. So I think I maybe have not explained that properly, but maybe we can do in the discussion. So the hot topics, what do I think are the hot topics for CVRM? The hot topic is how to account for perfusion abnormalities. For example, inhomogeneous perfusion in high-grade brain tumors, which is very common. Then, do we observe dissociations between CBF, CVRM, bold CVRM, and neurogenic bold? And especially, I would be interested if there are CVRM negative cases with preserved neurogenic bold, or vice versa. And then, does CVRM indeed prompt clinical decisions? I'm not sure yet. I'm just not sure. Maybe, Michael, you're doing some of it. Maybe you have some thoughts about it, but I'm just not totally sure. And then, with a relation to the resting state talk before me, can we do CVRM without challenges? It seems like we can. It seems like we can use resting state fMRI to extract CVR maps. Next slide, please. And there's one almost final slide now. This is an old work by Peter Banettini from 1997. And he looked, and this all goes into the issue of calibrated bold and normalizing bold. What he did, they recorded a map of finger movement and also of breathing carbogen. And then he divided the signal changes, like the bold signal, neurogenic bold by the CVRM bold effect. And you see that some voxels light up. What this means, I mean, they argued that CVRM could be used for improved localization because much of what we are seeing in CVRM is in a little different, geographically, it's a little in a different vascular bad territory than what we see in neurogenic bold. But what this paper shows, and that's why I'm showing it, there are definitely voxels where neurogenic bold is a bit higher than CVRM, bold CVRM. And this is what we should not normally think of, would not normally think of. So task-based fMRI can be more sensitive than bold CVRM in some voxels. Very important. So there is initial evidence of it, old evidence actually for it. So next slide, please. Final slide. Okay. So final quiz. I want your votes again. Does it indicate the need for revascularization, ESM, both or nothing? Your votes no. Okay, so you improved. And you probably noticed that I made a slight change. In the first slide I thought, is thought to indicate. Here I said, indicates the needs, and I also gave you the choice of nothing. So I don't know yet. Oh, yeah. Poster, we should see a pre-post comparison if this works. Ah.